myself Dr. Yash Joshi. Today I will be discussing glucose control in critically ill patients, an area that has undergone major changes over the last 2 decades of time. Hyperglycemia is extremely common in ICU patients regardless of whether they are known case of diabetes or not. Stress hormones, inflammatory mediators, insulin resistance, steroid therapy and vasopressor use, also nutritional support all contribute to the elevated blood glucose levels. Historically, clinicians believed that maintaining the near normal glucose level would improve the outcomes. But however, over the period of time, large clinical trials demonstrated that overly aggressive glucose control can increase the hyperglycemia and even increases the mortality. In this presentation, we will review the pathophysiology of hyperglycemia as well as some landmark clinical trials, current guideline recommendation, insulin infusions protocol, perioperative management and certain emergencies like DKA, hyperosmotic hyperglycemic state and hypoglycemia, and what are the future direction in glucose management. Now, stress hyperglycemia can occur in both diabetic as well as non-diabetic patients. During critical illness, there is activation of stress response causes increased secretion of cortisol, catecholamines, glucagon and growth hormones. These hormones stimulate the hepatic glucose production through gluconeogenesis as well as glycogenolysis. At the same time, inflammatory cytokines such as TNF alpha as well as interleukin 6, this all signaling pathway resulting in the insulin resistance. The consequences is elevated blood glucose despite of normal or even elevated endogenous insulin levels. Persistent hyperglycemia has been associated with increased infection rates, prolonged mechanical ventilation, AKI, longer ICU stay as well as increased mortality as well as morbidity. Now coming to the pathophysiology part, in critical illness, the body enters in a catabolic state designed to ensure that glucose availability to the vital organs such as heart, brain is available. However, this adaptive response becomes maladaptive when glucose level rise excessively. Multiple ICU intervention also worsen this process. These are steroids administration, use of vasopressor therapy, dextrose containing fluid, parenteral nutrition and extracorporeal circulation and sepsis. Inflammatory cytokines further progresses to insulin resistance, so skeletal muscle glucose uptake decreases while the hepatic glucose production increases, so there will be hyperglycemia. This result is persistent hyperglycemia despite ongoing insulin secretions. Hyperglycemia can adversely affect almost every organ system. At the immune level, it elevates the elevated glucose level impairs the neutrophil, chemotaxis, phagocytosis as well as bacterial killing. So this predisposes to patient to infection. In surgical patients, particularly cardiac surgery patients, hyperglycemia increases the risk of deep sternal wound infection, mediastinitis and delayed wound healing. At the vascular level, hyperglycemia promotes the oxidative stress, endothelial dysfunction and platelet activations and microvascular injury. Clinically, this all manifest as prolonged ventilation, ICU stay prolongation, multi-organ dysfunction and increase the morbidity. Now coming to the target blood glucose, the ideal glucose target in critically ill patient has been debated extensively over the period of time. Modern ICU practice favor the moderate glucose control rather than the strict normalization. Current American Diabetic Association and Society of Critical Care Management recommended that generally the target blood glucose below 180 mg per deciliter favors the most for critically ill patients. Earlier protocols aimed for 80 to 110 mg per deciliter, but subsequent studies demonstrated that increased risk of hypoglycemia with this aggressive type of management. Current management focus on mainly 3 principles. First, avoiding the severe hyperglycemia. Second, minimizing the glucose variability. And third, preventing hypoglycemia. Target should be individual based on patient characteristic and nutritional state. Okay, now we will discuss certain landmark trials regarding this. First is Leuven trial. The Leuven trial by Vanderberg in 2001 was a landmark study. In this study, they involved the surgical patients and many of them were cardiac surgery patients also. Patient receiving intensive insulin therapy which targets the blood glucose around 80 to 110. This trial shows there is a decreased ICU mortality, sepsis, renal failure, and ICU stay. So the benefits were especially seen in the patient requiring prolonged ICU care. So this trial study influenced the ICU practice worldwide and initiated the era of tight glycemic control. Followed by that, NICE sugar trial came. The NICE sugar trial later challenged the concept of intensive control. This large multi-center trial compared the intensive control, that is 80 to 110, versus conventional control, that is less than 180 milligram per deciliter. Surprisingly, intensive therapy increased the mortality, severe hypoglycemia, and other complications. This trend changed the modern ICU recommendation, and today most ICU prefer moderate glucose control rather than the extremely tight glucose target. Now coming to the GLUC-control trial, the GLUC-control trial evaluated the intensive insulin therapy in ICU patients. This study was stopped early because increased hypoglycemia, some safety concern, and the lack of mortality benefit. This further reinforced the concern regarding the aggressive insulin therapy. Now coming to the cardiac surgery and hyperglycemia, cardiac surgery patients usually represent a unique high-risk population because cardiopulmonary bypass triggers a profound inflammatory response, stress hormone release, and insulin resistance. Poor glycemic control in this patient has been associated with low cardiac output syndrome, atrial fibrillation, renal dysfunction, sternal wound infection, as well as the increased mortality. Therefore, glucose management remains an important component in perioperative cardiac surgical care. Now, what is the STS recommendation? Now, for the Society of Thoracic Surgeons recommend that maintaining glucose level below 180 mg per deciliter in cardiac surgery patients. Continuous insulin infusion is preferred because it allows the rapid titration and stable glucose controls. Frequent glucose monitoring is also essential. In selected patients with prolonged ICU stay or mechanical circulatory supports, target closures to the 150 mg per deciliter may be beneficial. The key message from the STS guideline is used of protocol-driven insulin therapy rather than a fixed approach. Now, coming to the monitoring of the blood glucose, accurate glucose monitoring is the cornerstone of the safe insulin therapy in the ICU patient. Frequent monitoring allows the early detection of both hyper as well as hypoglycemia. Whenever possible, arterial blood gas samples are preferred over capillary samples because they provide greater accuracy in critically ill patients. The point of care glucometers may become unreliable during shock, severe anemia, vasopressor therapy, peripheral edema, and poor tissue perfusion condition. For patients receiving intravenous insulin infusion, glucose measurements are typically obtained every hour till the patient becomes stable, and then after every 2 to 4 hours depending on the patient's protocol as well as condition. Remembering that insulin adjustments are only as good as the glucose measurement guiding them. Now coming to the insulin infusion therapy. Intravenous insulin infusion remains the preferred method of glucose control in unstable patients in ICU. Regular insulin has a short half-life, approximately to 5 to 9 minutes, allowing the rapid dose adjustment and quick reversal if hypoglycemia develops. Compared with the subcutaneous insulin, intravenous insulin provides better glucose stability, and particularly it is useful in patients with hemodynamic unstable patients requiring higher vasopressin supports, fluctuating nutritional intake, or rapid changing in the clinical condition. Subcutaneous insulin absorption may become unpredictable during shock, peripheral edema, hyperapnea, hypothermia, or vasoconstriction. Long-acting insulin is generally avoided during early phase of the critical illness because insulin requirement can change dramatically over the short period of time. Now coming to the how to initiate the insulin infusion. There are many protocols. Many ICU utilize the standard insulin infusion protocol to reduce the variability and improve the safety. In this protocol, if the blood glucose exceeds 180 mg per deciliter, an intravenous bolus is calculated by the current RBS divided by the 70. For example, if the patient's blood glucose level is 250 mg per deciliter, by dividing it to 70 gives it the value of 3.6, which is round figured to 4 units. So the insulin infusion is started at the same rate, that is, we will give the 4 units bolus and start the insulin infusion at 4 ml per hour. If the blood glucose level is below 180 mg per deciliter, there is no need for the bolus dose and we will just start the insulin infusion. So in current example, we'll just start the insulin infusion at 4 units per hour. Now we'll discuss the Yale insulin protocol. The Yale insulin infusion protocol is mainly used over the worldwide. It adjusts the insulin based on the current glucose and the rate of glucose rise. This dynamic adjustment helps to reduce the glucose variability. Patients usually require hourly blood glucose monitoring. Now this is the total Yale protocol in this one chart. First we'll check the initial blood glucose. Now after 1 hour we'll again check the blood glucose level. Now we'll see in which range our current blood glucose is coming. Like if it is between 140 to 190, more than 200, or if it is less than 100. So we'll see if the blood glucose rise is more than 50 milligram per hour. It is between 1 to 50 milligram per hour, and then we will change the insulin infusion accordingly, which is instructed here as a 2x, x, and so on. Now we'll come to the perioperative management. During the surgery, particularly cardiac surgery, blood glucose level can rise significantly due to stress, catecholamine release, corticosteroids, and cardiopulmonary bypass. Frequent glucose monitoring is therefore essential. Intravenous infusion allows the rapid correction of glucose excursion. Most current guidelines recommended that maintaining the intraoperative glucose level below 180 is recommended. The focus is on stable glucose control rather than the achieving strict normoglycemia. Now coming to the transition to subcutaneous insulin, once the patient condition stabilizes, the ICU insulin infusion is no longer required, and we will transition to the subcutaneous insulin, which must be carefully planned. The total daily insulin requirement is often estimated approximately 0.05 to 0.8 units per kg per day. So typically 50% of this daily dose requirement is administered as basal insulin, that is longer acting, and remaining the 50% is divided into the meal related bolus doses, which are short acting insulin. An important teaching point here is that the basal insulin should be administered 2 to 4 hours before the stopping of intravenous insulin. Failure to all of these therapies can result in rebound hyperglycemia. Now we will discuss about certain special population. Certain ICU population require individual glucose management. In patients with renal failure, insulin clearance is decreased significantly, so increasing the risk of hypoglycemia. Patients receiving corticosteroid often require higher insulin doses because of steroid-induced marked insulin resistance. Trauma patient, neurocritical care patient, septic patient, and cardiac surgery patients may all demonstrate the unique glucose patterns require frequent reassessment of the patient. There is no single glucose strategy which is suitable for every critical ill patient. Now we'll coming to the certain emergencies which are related to the glucose management. First is diabetic ketoacidosis. Now diabetic ketoacidosis develops when there is insufficient insulin action in the body. Because of glucose cannot enter into the cells, the body perceives a state of starvation despite the high blood glucose levels. Counter-regulatory hormones are raised that stimulate the gluconeogenesis, lipolysis. So fat breakdown generates the ketone bodies, which are the beta-hydroxybutyrate and acetoacetate, which causes the metabolic acidosis. At the same time, severe hyperglycemia causes the osmotic diuresis, leading to significant water and electrolyte loss via urine. So most of the patients have fluid deficit approximate of 5 to 8 liter at presentation. The most common precipitating factor worldwide remains the infection. Other certain common causes for DKA includes the missed insulin doses, MI, stroke, surgical stress, trauma, certain medications plus like steroids and SGLT2 inhibitors. Now, what are the clinical features? Patient usually present over the hours or days. Early symptoms are related to the hyperglycemia and dehydration. As acidosis worsens, patient develops nausea, vomiting, abdominal pain, and the most characteristic hallmark feature is coughing respiration. Diagnosis requires the presence of hyperglycemia, ketoacidosis, and metabolic acidosis. One of the common mistakes is diagnosis the DKA on the sole base of the glucose level. The diagnosis should always include the evidence of ketosis as well as the acidosis also. The particularly important laboratory concept is a potassium. Although serum potassium may initially appear normal, the elevated due to acidosis, total body potassium stores are usually profoundly depleted. Now coming to the management of the diabetic ketoacidosis, the management is protocol driven. The first intervention is fluid resuscitation because most of the patients are severely dehydrated. Fluid alone may significantly reduce the blood glucose level by improving the renal perfusion. Insulin therapy is usually started only after the potassium value has been assessed. If the potassium level is below 3.3 milliliter per liter, then insulin infusion should be withheld until the potassium replacement is initiated. A key target point is that the insulin should not be discontinued when the glucose normalizes. Insulin must continue till the ketoacidosis resolves and the anion gap nearly equal to become normal. Now coming to the special types of DKA, that is euglycemic DKA. Euglycemic diabetic ketoacidosis is becoming increasingly most important because widespread use of the SGLT2 inhibitor like dapagliflozin. In this patient, glucose level may appear relatively normal, leading to delayed diagnosis. Therefore, any sick diabetic patient who is taking SGLT2 inhibitor should be evaluated for the ketoacidosis as well as acidosis if the blood glucose is markedly elevated. Now we will discuss the diabetic ketoacidosis versus the hyperglycemic hyperosmotic state. The major difference between the DKA and HHS is DKA is dominated by the ketoacidosis as well as acidosis, where HHS is dominated by severe hyperglycemia and hyperosmolarity and dehydration. Mortality is usually higher in HHS. HHS is another hyperglycemic emergency. Unlike the DKA, here ketoacidosis is minimal because some insulin in body is still present. So this insulin is enough to suppress the lipolysis and ketogenesis, but it is not enough to control the glucose. Therefore, there is severe hyperglycemia which will lead to the raised osmolarity and it will lead to the extreme dehydration. Patient usually comes with the neurological symptoms like confusion and coma. Now coming to the hypoglycemia. Hypoglycemia remains the most feared complication of insulin therapy in the ICU. Severe hypoglycemia may cause seizures, cardiac arrhythmia, permanent neurological injury and death. Rapid recognition is therefore very much essential. Treatment involves immediate administration of the dextrose, temporary adjustment of or discontinuation of the insulin infusion, and frequent reassessment of the blood glucose level. The modern philosophy of ICU glucose control is not only avoiding the hyperglycemia but equally avoiding the hypoglycemia. Now the major message from this presentation is that glucose control in critically ill patients requires balance. Excessive hyperglycemia worsens the outcome, but aggressive glucose lowering can equally harmful. Modern ICU practice favors the moderate glucose control, frequent monitoring protocol driven insulin therapy and aggressive prevention of hypoglycemia. The goal is to safe and consistent glucose management rather than perfect glucose number. The future of ICU glucose management is likely to involve greater automation and precision. Continuous glucose monitoring systems are being increasingly invented and accurately may reduce the burden of frequent blood glucose sampling. Artificial intelligence driven insulin dosing and systems are being developed to predict the glucose trend and optimize the insulin delivery. Closed loop insulin delivery system, often called artificial pancreas system, may eventually become the part of the routine ICU care. These technologies have potential to improve the glucose control with minimizing the hypoglycemia and clinical workload. The key studies and the references for this are NICE-Struggle trial, Leuven trial, STF recommendation, ADA, that is American Diabetic Association ICU recommendation, and Society of Critical Care Management guidelines. Thank you.